I have to call the chairpersons. Dr. Namrata Sharma and Dr. Partho Biswas will shortly be with us. And in the expert panel, I would request Dr. Vaishali Une, please come over, ma'am. Sit here. And the others, Dr. Shilpa, yes, please come over. Dr. Nayana, please come. Dr. Nayana, just come and sit, take your seat here. Dr. Priya Narang, Dr. Natarajan, Dr. Shubhadra Jalali, Madam. They're right now not, and Dr. Arnab Mitra, sir. They are not here, so I think they'll be here shortly. So just we will go on with the session. We'll start the session. So can I have the video of this session, please? This is a complete new concept. Thank you. Just put the video off. The theme, as we say, progression and efficiency in science is beyond all bias, especially gender bias. That was the theme on which this was made. And not wasting much time, we'll go over to our first set of speakers in the topic. And no, not this one, this is later on. We have the first speaker as Dr. Sneha Jain. Come over. And with her will be walking Dr. Sugato Paul. Yes, welcome, ma'am. Ma'am, you can come and, yeah, please be there. Podium, yeah. Your video is there.
Sorry for the delay. Looking at this, life looks so serene, so calm. But you never know when you can have a bolt from the blue. A very good afternoon, everyone, sharing a similar experience from one of my surgeries. A routine day, a not so very hard cataract was posted for surgery, a phacoemulsification was planned. I was leisurely doing my capsulorhexis after making all the main ports, thinking of finishing the case soon and moving on to the next one. Once the capsulorhexis was done, a good hydrodelineation and dissection was attempted to make the nucleus rotate freely. Once that was achieved, time to start phacoemulsification. Before entering the phaco probe, time to inject some OVD, and while injecting OVD, bolt. The cannula got detached from the syringe and hit the nucleus. The nucleus was dangling partially in the anterior chamber, partially in the iris plane and trying to go inside the vitreous cavity. The very first instinct was to deliver the nucleus in the anterior chamber and preventing it from going down in the vitreous cavity. As the posterior capsular status was unknown, I decided to convert the case into small incision cataract surgery. A sclerocorneal tunnel was made in a different plane, and the nucleus was delivered with the help of Vectis. During cortical cleanup, the anterior capsule was intact, unharmed, but the posterior capsule, there was large dehiscence. So anterior vitrectomy and cortical cleanup was performed, and as the anterior capsule was unharmed, I was able to put a PMMA lens in the sulcus. This is the post-operative course. At 1 month, the vision was 6/9 and 8. The anterior segment picture, the fundus photo, and the OCT is unremarkable. Accidents are not uncommon during any surgery, and accidental release of OVD cannula is one of them. The incidence reported is 0.09% and 0.07%. These studies themselves claim that there is underreporting, and stromal wound hydration is the most common step when this can occur. Prevention is the best treatment. These are the steps which can be undertaken to prevent cannula-associated ocular injury. The OR assistant ensures tight fitness of the cannula. Surgeon rechecks it. Surgeon primes the cannula themselves to remove any airspace. Perform a test squirt outside the eye. Hold the hub of the cannula during injection and angulate it away from the posterior capsule. It is ideal to use a fresh cannula for every case. And thank you for your patient hearing.
We'll come to the discussion after Dr. Sugato Paul walks the same way. Let's see what he has.
Video, please. So I'll be presenting a similar sort of case, a bolt from the blue, where the cannula came out. Video. हाँ? हाँ, कर दीजिए वो. You have to be ready so that we don't lose time. हाँ. No. It's not there. So this is a straightforward case. To start with, I've done the corneal incision, nicked the capsule to do the rhexis. I'll be putting in OVD. This is how I normally do my rhexis. I nick the capsule with the keratome because the flap is raised, and I'm giving in OVD and see what happened. The cannula just came out like a bolt and struck the anterior segment and struck the anterior capsule. So at this stage, I took it out. It was a local loop cannula, but still it came out. So what shall I do? And the patient was having pain. It's under topical anesthesia. What shall I do? So I switched on my retroillumination to assess the injury, and that's what is the Argentine flag sign, where it is extended in both ways. And in this situation, how you proceed depends on the surgeon's expertise, grade of the nucleus, the comorbidity, and also whether to place the lens. If we decide to go ahead with phaco, we have to remember few points in mind, like minimal hydrodissection, minimal rotation, minimum lateral separations, and if we do phaco, try to be in the anterior planar phaco, and always try to maintain the anterior chamber and look for the wraparound extension of the tear, which in flap is a flap motility sign by Rohit Omparkash, and also have a plan B in this situation. Why is not moving? Yeah. So I decided to go ahead with phaco. Whether you do phaco or SICS, you have to have good access to the nucleus. So I had to extend the capsular tear. So nick the capsule on one hub with the Haldiputkar forceps, completed the hemirexis on this side. Now this tear was basically sub incisional tear. Argentine flag signs normally happens perpendicular to the incision, but here because it's of accident, it was sub-incisional. In this situation, sometimes it is better to change the site of the incision, but I wanted to proceed on the same site incision and decided to, while doing the phaco, just tilt the phaco tip slightly on the other side. So here I have completed one half of the rexis and completed the other half of the rexis and proceeded with the phaco. While rotating the nucleus, you have to be very careful so that no pressure is on the zonules. So I used bimanual rotation, and phaco also you have to be gentle with minimal lateral separation. And again, while rotating the nucleus, you'll notice I'm using the phaco tip as the fulcrum and then using the chopper to rotate against the phaco tip so that no pressure is on the zonule, because in this situation any pressure on the zonules and the tear can extend posteriorly. There are several ways of doing it. You can take a small pie and do the then it will give more space, but I decided to do small fragments of chops, gently rotating the nucleus, and once I got the chops, I took the nucleus out one by one very slowly. It's better to use low setting in this situation, and once the phaco is done, you again reassess whether the tear has extended, because the placement of the lens will depend on that, and never allow the chamber to decompress. So this is how you put before taking the phaco tip out, you have to put viscoelastic in the anterior chamber. So IA should be gentle as well with sideways movement, and you have to be very careful where the tear has extended. So I had good rexes on two hubs, so I decided to put in the bag lens, and also I didn't have actually the option of three-piece, multi-piece lens on that day. Otherwise, I would have probably put the lens in the sulcus, three-piece lens. So I put the lens and rotated the lens in a way where it's not on the extension and completed the case. Thank you.
Very well demonstrated by two very efficient surgeons about accident which can happen to all of us, not only in phaco but even in SICS of hydrodissection. So I would come to our expert panel, Dr. Vaishali ma'am. Vaishali ma'am, what amount of this was done in visco mostly, and for Sugato it was in hydro. So what precaution would you take? Already Dr. Sneha Jain has told us, so the amount of force, the amount of fluid, she has told us some steps that we have to look into. Please, can you have some expert comments from you also? Visco. Oh, so this was again in the visco stage. So
Yeah.
the amount of visco or the cannula, would you have some suggestions on that?
Thank you, Dr. Sudipta, and let me first congratulate both Dr. Sneh and Dr. Sugato for excellent managing because we tend to become so panicky in this situation. So it's easier said than done. That okay, don't panic and all, and both the cases were excellently managed. I would just I thought, I don't know what I would have done in that case, but in Dr. Sneha's case, I think there was a bit of over pressure of due to the fluid,
Forceful
which
pressure.
forceful, yes, which caused the nucleus to pop up, whereas in Dr. Sugato's case it was very well managed, and I like the one who dares finally be successful. So I really congratulate you for completing the rexes as well, because he has very well said that the surgeon skill also matters. So I would say that those who are beginners, or they better not try in a Argentinian flag sign. So it's better to avoid what usually is done to be on the safe side. Yes, convert, do an SICS is equally good. But hats off to Dr. Sugato also for completing the rexes. I felt that was really great, and the overhydration in the first case. That's
Okay.
all. Thank you.
Thank you, ma'am. And from Dr. Nana, we would like a word from you also
Thank you,
regarding Dr.
Sudipta.
Sneha Jain's case.
Right.
And then maybe
Okay. I
Dr.
think she
Sugato.
has handled it very nicely. And as Dr. Vaishali said, there was no panic scene in the moments also what she was doing. And
Would you have suggested,
yeah.
she had retrieved it by SICS. Would you have suggested putting in any tricot and then looking into it if there was any, she did, if it, some vitreous was there in the anterior chamber
No, it
before
is
she
not
closed it up?
mandatory to put tricot. I think it's not mandatory. And one thing I would like to say, sometimes in a hurry we push the visco very fast.
Correct.
So it should be pushed in a graded manner. You bring the visco to the tip and then introduce into the anterior chamber, and then with grade allow it to disperse and then push. I think that will take care. Secondly, I also tell my residents to reconfirm whether the lock is properly put. That is the most important thing, because the sister or the staff, they in a hurry, they may not have secured it so well. And another important thing which I feel this can happen is that the entry is too small and you are struggling to enter with the cannula. In that case, this can also happen. Then once you enter, you push it very vigorously. So the side port or the incision has to be adequate. I think that will also help.
Thank you, ma'am. And can we have, yes, yes. Yes.
Just one last thing that I noticed, that in not only about the rexis and this, but also there's a chance of dangerous of hurting the corneal endothelium as well, because it just spurts and then so that care is also to be taken. Proper OVDs are necessary.
Can we have a word from the chair finally to sum up the case?
Okay, not to sum up the case, but I just thought Dr. Sugato was in the wrong hall in the wrong time. You should have been in the hall F at 2:30. That's where court martial begins, yes. So, yes. So I think excellent management, Sugato, and these things will happen maybe once or twice in a lifetime. But one thing that, for our younger colleagues, I would say that it was a lower look syringe, but even if it is not a syringe with a lower look, then also 2 fingers on the hub is mandatory. And all of us have saved by a pinch of those 2 fingers while injecting so many times. The sisters in a haste would have not given a tight screw to it, and then this can be a miss. But that 2 fingers is very important. Number 2 is, all of us, especially in our hospitals, we should have a library of lenses, of 3-piece lenses, which I think becomes mandatory not only in such cases of accidents, but also for PCRs as well. So at times it's not possible, but that would be a very, very ideal situation.
Thank you, sir. Yeah, there's a question from the audience, I think. So yes, Pranab. Okay, I think, yes, any one of you can take up that question if you want.
Okay, I'll take up these questions. If your cannula, if it hits the base of the iris and if there is a bleeding, if it's a spontaneous, if it's a huge bleeding, you cannot do anything except that, you have to keep the eye tight and you can inject good amount of OVD. You sit there and wait till it pauses. Then again, maybe after 30 seconds or maybe 50, 60 seconds, you go ahead again, wash it out and just see again. And again, if you have a bleeding, again, then you have to inflate it and wait. That's what actually I do. Secondly, you had a second question where you place the haptics. The haptics, if you have a cut like this, you need to place those haptics like this. It should be perpendicular to that. For the first case, I just had one more question. I don't know if I missed it. I don't know. You had a dangling nucleus, right? And you then converted it into an SICS and you explanted. I just missed, what lens did you put inside? You, okay, you placed. Okay, perfect. I think that's pretty good. An alternative to that, what I would have done alternatively would have been, levitating it into the anterior chamber and because your anterior capsule was intact at that point of time. So I would have just taken a 3-piece intraocular lens and injected beneath that, because your lens was not very hard. So IOL scaffold could have been done very easily. You could have, dialed the same IOL and then. You started with a small incision. Okay, then it is fine. Then you already have an incision, so you ended up with that. So I think that sounds good.
Can I have a quick question to the expert panel? Like, in this situation, if we are putting a single piece lens, as I did, and place it perpendicular to the thing, is it better to use hydrophilic lens than hydrophobic? Because if the hydrophilic lens haptics comes out over the anterior capsules, they cause less damage, or they rub against the iris less than the single piece hydrophobic lenses. Is it so?
Sugato, not really, I think, single piece lens with its malleability and the pliability will always occupy less space, whereas if it has to go into the sulcus, it should be a 3-piece lens.
Thank you.
Absolutely.
So I'll call the next speaker. none
Another
other than
one thing that you had asked about how to manage the bleed, even putting simple air will also help in bringing down the bleeding, and you can it will cause a tamponading, and that also can help.
I'll quickly tell you. See, air, as madam said, if it is a very small bleed, maybe it can take care. But if it is a profuse bleeding, which could have had in Shugato's case, it will bleed and bleed and bleed. And especially if the base of the iris has been detached, that bleeding will not stop very quickly. So viscoelastic, and not only methyl cellulose, if you have high molecular viscoelastic, give it a good pace and make sure the pressure with your finger pressure is tight. It should be tight. And what we, as surgeons want to do is want to go over the situation quickly. Let at least 2 to 3 minutes elapse by the clock. Then only try and remove the visco and see that if it is bleeding. And what someone said, that again refill if it is still bleeding. Most of the time it will stop.
I had one of the case till now, since so many years I had one case where I had to abandon the surgery because of high FEMA. There was no way it was going. I waited for so many minutes and it was just not going. I just winded up, took a Tenno suture, closed the incision, and I started the patient on drugs so that the pressure does not rise. I told the patient was on other anticoagulants and everything. So I just explained to the patient that, look, you are having this. I am going to put a lens in your eye, but give me few days. I waited for 3-4 days, and then there was a big clot which formed, and then I took the patient. I just very carefully removed that clot, and then I placed the intraocular lens. So once I had to abandon the surgery also.
This is very good discussion. I'll just give one
so
small, because the clot, dislodging the clot at that point of time is not judicious at all. The clot has sealed it. So, taking of the clot again will rebleed. So even if there is a clot, let it be. Put in your lens, just give a Ghosh wash and go ahead.
Thank you so much.
best
Because
thing
of
is, I
short
think,
of time,
time, yeah.
I'll request Sudipta to start her presentation. With Sudipta walking will be Dr. Siddhartha Ghosh, and they'll be presenting Peekaboo,
For my presentation.
trouble in managing small pupil.
I, at the outset, thank the scientific committee of AIOS, and I'm really honored to be here. My topic, Peekaboo, troubles in managing small pupil cataract surgeries. Please put the audio slightly down. Put the audio down, volume. So pupils like this, which are small but can be managed when rexis can be done with visco dilatation or any other methods, and this is a hard cataract that I was dealing, can be done well if you do a vertical chop and the chops are complete and you can lift the nucleus up. But then, as you see, we are going very close to the margin of the iris, so there might be some difficulty, but if you can lift up each piece and the case becomes uncomplicated, even with a small pupil you can manage, but not always. Sometimes we are not lucky enough And this was a case of a 90-year-old lady who had deferred her cataract. The pupil wouldn't dilate with anything. No financial interest. We used Phenokin Plus, we used adrenaline, we used all possible methods. I did a bit of viscodilatation, and this was an intumescent cataract. So after the nick with the cystitome, I went for decompression, sucking out the free fluid, went for a Rexis. But I would say, back of my mind was like, I need a standard Rexis, but see what happened. In between, I had a smaller Rexis. Then I desired it was a brown cataract, which I discovered later on. So this was first trouble that we might have if you have a small Rexis. So we need to enlarge this Rexis, but I thought let me go on with the steps. I would enlarge it later. So that's a brown cataracts, and see, she had comorbidities, so we had a fluttery iris as well. Still then we went on with a direct chop, and the second trouble, the vertical chop did not work well. There was a central leathery cataract behind, so there was a failure of direct chop. So now we had to plan it differently, because now we had to go for a multiplanar or whatever, which was not working, and all this manipulation finally led to the pupil going further smaller, and the iris was getting in my way. This is a IFIS which I had. So all the troubles of a small pupil that I finally landed up with, and had to take a decision of having some pupil dilatation before I could deal. And this is something that I really love. I've been using in universally the iris hooks. I used 5 of them, and then I went in. First thing I did was a cut at the Rexis margin, and then with microrexis forceps tried to enlarge my small Rexis, which was the first trouble that I had. So I did it. I tried to do it as gently as possible. It was a standard size that I could enlarge the pupil. This was done well. Now dealing with the nuclear part, I thought of a multiplanar chop. So again, at the positions where I had done some chops, I went in again and did some other, deepened the chops there. And finally I could get hold of small pieces, try to lift one at a time. Slowly but steadily my case looked better. I started debulking from the periphery because the center was still attached. But finally it was much better than how I started, how I dealt with it in between, and finished off my case. Now here I had to remove my iris hooks because I wanted the pupil to go back. See, I had a lot of iris prolapse in between, so there was a lot of IFIS. So without injuring, slowly I put the IOL in the bag. All looked good. And the lesson that I learned, that never to start with a piece in a small cataract. So I will give over to Dr. Siddhartha Ghosh for the next presentation, and we'll have the discussion later.
While Dr. Ghosh is getting ready, I'll request Dr. Priya to give few tips to the juniors. I think Sudipta managed well, let go of her ego as a surgeon, and took the right steps of putting the pupil iris hooks, or would you have continued it in the same way?
No, I think she beautifully managed the case, and everything, what was appropriate at what stage she did it. Maybe she tended to have a comparatively bigger Rexis in the beginning. She would have avoided quite a bit of it. But anyway, we do not always have things going our way the way we plan it. I think she did the perfect job. I don't think anything differently that I would have done for the patient.
Thank you, ma'am. Dr. Ghosh, if you can start your presentation.
Good afternoon, everyone. Thank you, Chairman Scientific Committee, for this opportunity. It's a wonderful program. Well, in the next a few minutes, actually, we are going to see how, small pupils are really very common, and it could be in innumerable settings that we can have this, and so many devices can be used. Here I am going to show you a very special situation, uveitic cataract, and these pupils are really very unpredictable, and that is how it goes. This is a 46-year-old male who had recurrent episodes of acute anterior uveitis in both eyes, now quite for maybe 3 months, and he had presented with dimness of vision in the right eye for about 6 months. So he needed a surgery. As you can see, it's a white cataract. After injecting viscoelastics, I use a blunt spatula to just separate those, the additions, the synecholysis has to be done. So synechia is taken care of with this blunt spatula gradually. And then I peel off the pupillary, membranes. Those little things can really make these pupils very taut, and after removing gently those pupillary membranes, I stretch mechanically with two instruments so that we can accommodate a pupil expansion device. And since these pupils are really very unpredictable, what we do is we invariably would like to place a pupil expansion device so that we have adequate view of the capsule and we can fashion a decent size capsular axis. Since it's a white cataract, we needed to stain it, and I stain it under the viscoelastic so that it's properly stained without much hindrance. And then after removing this stain with viscoelastics, I try to fashion as big a possible rexis. It should be adequate actually, so that rest of the procedure remains comfortable. But, remember, this is a white cataract, so I needed to be very slow and meticulous so that nothing adverse happens. So in between I come out, inject more viscoelastics, and then gradually make sure that I have a large enough rexis. And thereafter, with little hydro procedure, it's a soft cataract in any case, so I did a little hydro procedure and then start with the phacoemulsification. It's really soft, so it might not crack properly. It comes out as flakes, and what I make sure here is we need to be gentle, slow, and we need to remove every bit of the cortex. Like, that is very important in these patients, because we cannot leave behind anything. We need to, if required, we need to, go behind the iris and pull out those cortex clumps which may be adherent at places. And we need to make sure that we have removed everything that is there. And then I inject a PC IOL. It is hydrophobic acrylic IOL here. It's in the bag. And again, after placing the IOL properly and dialing it, we remove the pupil expansion device. We need to do that, and thereafter we clear out all the viscoelastics that are there from also behind the IOL that I am doing now. We need to make sure that we take out all the viscoelastics so that they don't react later. So there are many lessons learned from this kind of a case. The first thing I'd like to highlight is, synecholysis and pupillary membrane removal is very important in these patients. Anterior capsule painting with trypan blue under the viscoelastics is really important, essential, because it's a white cataract. And judicious use of pupil expansion device may aid in achieving an adequate size capsular axis, and of course aids in visualization, and the choice of IOL should be right in uveitic cases. Thank you.
Thank you, Dr. Ghosh. Nice teaching video. Dr. Mitra, any comment?
Before, no, before that, I just had a question. Do you give any steroids for this patient?
Yes, sir. Pre-op, we start steroids. I start oral only. This patient, because he had recurrent histories, so we start steroids 3 days prior, oral steroids. And
what about Subtenon at the end?
Sir, I did not use Subtenon. I generally don't, because if these patients are, they are generally not responsive to steroid. But if they are, then it will be difficult to remove the Subtenons. So oral 3 days prior, and then topical we follow. And of course, I use a mydriatic cycloplegic drug. So the cycloplegic is important at least for the next 7 days.
Any comment from any one of you? So I'll request you to sum up the case because of the lack of time.
Okay.
We're running slightly short.
I think the case was beautiful. Everything was perfect. The only thing that I would have done differently in this case I would have not used any ring. I would have only used an hook, iris hook, because it's unpredictable. We don't know how things turn up upside down during these kind of complicated surgeries. In a normal routine surgery, all rings are fine. But for such specific cases, I always try to use hooks, because if there is a complication, the first thing is you have to remove the ring, and then again you have to use something to dilate the pupil. So that's a hook. So I usually begin with it in such cases. Otherwise, it was perfect. Very nice.
And to continue that, I work in a government setup, so financial constraints are there. So I would have, in this case, I would have just done sphincterotomies and completed. Thank you. Wonderful case.
Thank you very much for your nice comments. So I'll hand over to Sudipta for the calling the next speaker.
Yeah, we have our next speaker as Dr. Shibashish Dash, and with him will be Dr. Deepa Shaha, walking in a case of posterior polar cataract. Over to Shibashish.
Good afternoon, everyone. I'm Dr. Shibashish Das. So today we'll be talking about posterior polar cataracts. I'll be presenting a regular case. We'll be discussing the regular points about a posterior polar cataract, how to manage one. Then we'll go into, with our next speaker, we'll go into the complications part. So this was a regular case. In many cases, if we have access to high-grade anterior segment OCT, before the surgery is planned, we can see if there is a if there is adhesion to the posterior capsule or not. But many times we do not have such. In these cases, we'll avoid to hydrodissect. We'll just hydrodelineate, look for the golden rings. Hydrodelineation is also not required. As most of these cases, the nucleus is very soft. It is not possible in many cases to have a proper to chop the cases. So we'll try. In this case, I've tried, but once it is not that I'm not getting a chop or I'm not able to rotate, I'll not try aggressively to chop or rotate the nucleus much. So in this case, I've cleared out as much as possible from the central area. Then as it is here, that I'm trying to hold a edge. When I did not find the edge to hold, I refill my chamber. I do a slight bit of hydrodelineation again. Now I get an edge. Now with the help of viscoelastic, I'll just lift up the edge more, push back the PC more. This is the epinuclear plate that is there. That was hydrodelineated at first. So with the phaco, I could take out this the hydrodelineated epinuclear part. So once this was removed, now I have been left with the last plate with the posterior polar in place. So one more important point here is after removing the epinuclear plate, do not take out your, what I follow is I do not take out my phaco handpiece. I keep the irrigation on because I do not know what is the status of the posterior plate. So I push OVDs through my left side port. Then the last plate I would prefer to remove it by IA, by the aspiration. I follow a centripetal like pattern. From the edges, I will not try to take it out. The central part I do not cross. From the edges, from 360 degree, I try to bring in the edges to the center as much as it is coming. And the last central part will be the last piece that I'll take out. So even if there is a dehiscence, so I have quite a bit of backup so that not much is lost during the process. So here you could see that I was lucky enough that I could complete the case. So the points to remember, it is do not hydrodissect, hydrodelineate, do not be too aggressive, do not try to chop or rotate forcefully. Maintain the AC at all times. Whenever if you are coming out of the AC, try to fill in with OVD before you stop your irrigation. Take away the last bit centripetally. And to my young colleagues, I would like to say that many times it becomes for us when we are operating, it becomes like a race against time. We try to compete how fast we can finish 8 surgeries, 10 surgeries. It is not a race against time. Take your time, be calm. If you are comfortable, go for a peribulbar block. No need to do these cases under topical anesthesia if you are not comfortable. Be slow, be calm, but still if you have some complications, my next speaker will be guiding you for the steps to take care of the complications. Thank you.
Thank you,
I have
Shivashish.
a question
And,
for you. Let her keep the laptop. Sorry. No, I just want to know whether do you take any special inform? No, keep your laptop, so don't waste time. No.
Yeah.
No. Do you take a special informed consent for posterior polar cataract for dislocation of nucleus or cataract?
Yes, sir. Before the surgery, I always explain it to the patient via a
No,
diagram.
you take an informed consent, right?
Yes, yes, sir.
But
I do take that.
I have made it a point that we do it.
I always,
and then also sometimes some patient asks, what do you do? So we also ask for a standby VR surgeon, and we take the fee also, so that the patient knows the importance. And in case the lens falls, same time do the vitrectomy and put the lens.
correct, sir.
very,
So,
very good point pointed out. Thank you, sir. Deepa, are you ready? Yeah, okay.
Hello. Yeah, I'm Dr. Deepa from Kolkata. It's a great pleasure to be a part of this program. Now, in working hand in hand, my topic is managing the sinking plate. The term sinking plate reminds us the tragic story of Titanic. But in my case, anyhow, I was able to save my case of Titanic. It's a 38 years old myopic female with a soft PPC. The IOL power was 16 diopter. Usually, I prefer to do clear corneal phaco, but here, from the history, it suggests that there is a high chance of PCR. So that's why I did this limbal tunnel and continued my phaco. After doing this, I started the Rexis. The Rexis was of adequate size. It was complete. Then I did the side port and main port. As we all know that hydrodissection is contraindicated, so I tried to do the mechanical dissection. It will separate the capsule, anterior capsule from the cortex. Then I tried to do in-out hydrodissection or delineation. I don't know how much successful I was there. And then I did a central trench with a very low infusion rate. Now here the cataract was very soft, so I manipulate the lens matter, then I try to aspirate them and tried this step repeatedly. And whatever the nuclear matter was there, I tried to separate those in a piecemeal fashion. Now while doing so, I just noticed this part of the nucleus was very sticky, it was very difficult, and I was guessing something would be wrong there. And after some time, I noticed there is a break in the posterior capsule. And there is a PCR. So immediately I put the viscoelastic, try to stabilize my vitreous phase, and then I thought I could remove this part with the phaco probe in a epinuclear mode, but this was my great mistake. As I tried to do this, some of the cortex I could remove, but my PCR increased, though the parameters was very low. Then I thought I could take the help of the Simcoe, but this part was very sticky. Then I tried intravitrectomy and tried to remove the cortex, but while doing so, a few chunks of cortex went down, but most of the part I was able to remove. And then I put the PCIOL in the sulcus and completed my case. The patient came on the second post-operative day. The vision was quite good. It was 6/9, and there was no reaction in the anterior chamber or in the vitreous phase. I explained this to the patient and asked her to keep follow-up every 15 days and added the oral steroid. So my take home message is, though I followed all the cautious step for this posterior polar cataract, but a single mistake changed the course of the pathway of my surgery. So one thing is very important. If there is a PCR, no such procedure should be done that risking the extension of the tear. So thank you all. Thank you
Yeah,
for your
thank you,
patience,
Deepa. And
very-
just before we go on to the next speaker, please, Dr. Sangeeta, you can come over as we go on in this discussion. Dr. Shilpa, was she correct in the way she withdrew her probe after noticing that PCR, one thing, and could we have used a tricot? And another word from Dr. Priya before we sum up this case.
Yeah,
Just Dr. Shilpa, please
that's
go on.
exactly.
Please
First
put
of
your-
all, congratulations. You managed it wonderfully. What I would do differently is you said that you felt something was wrong. The pieces were not coming properly into the probe. That is when you realize that there could be a PC rent. So very important not to just come out, wait there, bring down your bottle height, reduce your parameters, inject an OVD, and then make sure that the anterior chamber is properly formed and then come out. Because then, even if you have a rent, it will stay there, it will not extend. That is one thing. And secondly, I think when we should realize that there are different types of posterior polar cataracts. So when you see pre-operatively that there are radial folds coming towards that PC, the polar cataract, that means that you need a VR backup.
Correct.
But when you see that there are no such folds, you can probably say, I don't need the help of the VR.
Thank you, ma'am. And Dr. Priya, quick
I
word
will,
for
I will
Dr.
add
Priya.
one quick thing. The biggest mistake, everything is fine, we all make mistakes, but the biggest mistake is when you are having a PCR, you should not enter the eye with the phaco probe. That's the biggest thing. The surgery should have halted at that point. You take a Tano suture, close down the corneal incision, make a pars plana incision, go through that, do a not a posterior but a pupillary vitrectomy. I'm not saying to do anything extra, but you need to clear out all the vitreous which is pushing up from behind. Now, because when you go from the pars plana side, you are shaving off all the vitreous which is there in the pupillary plane. If you do the same thing from your corneal wound, you will be cutting down a vitreous, but you will be still having some amount coming up. So you need to first block that. Having blocked that, if you know that you have a good amount of rhexis, you just inject the intraocular lens. Whatever lens matter remains on the top can be removed with the vitrectomy probe and with the phaco probe. So it can be easily managed. But when you have a big PCR going in with a phaco probe, thinking that you can pick up that nuclear material, it's only going to enlarge. And
Thank you,
create
ma'am.
a lot of complications.
And with that, we go on to our next speaker.
That can I
Yeah.
just
Yeah, just ma'am, after this,
Can I
Dr.
ask
Vaishali,
the-
can you just have her
Okay.
presentations,
Yeah,
please?
I needed sir's
Yeah,
opinion. We
yes,
can
of
have it.
course, we will have sir's opinion on this, definitely, because the next is Pandora's Box by Dr. Sangeeta Roy. So let's look into what she has in her Pandora's Box.
Good afternoon, everyone. This is one of those atypical OT days when things keep on going bad in one case. So, volume.
In Greek mythology, once upon a time, Pandora opened a box which led to many unforeseen problems. I opened one such on this particular day. A 65 years old female patient was shifted to my OT with a decentered IOL. I planned to do an anterior vitrectomy and scleral fixation of the existing IOL. anterior vitrectomy, one haptic was exteriorized and the assistant was asked to hold the haptic. The assistant pulled it a little hard and the haptic came out. Then a superior tunnel was made and the IOL was explanted. While doing the anterior vitrectomy, the other haptic was seen floating in the anterior vitreous. While attempting to take it out, it broke and a small piece dropped down. So I had no other option. I had to do a vitrectomy to remove the haptic. A 25 gauge entry was made through the existing scleral wound as it was such hypotenuse that I could not take any other port. As soon as I entered the vitreous cavity, I saw vitreous hemorrhage. So thorough vitrectomy was done. PVD induced.
As it is, we are scared and the music is scaring us further.
While doing a peripheral vitrectomy with indentation, I saw a CTR. So trial was made to remove the CTR. And the CTR was removed with a rotatory movement. So a complete vitrectomy was done. Even after 360-degree indentation, I could not find the broken end of the haptic, for which I actually started the pars plana vitrectomy. And then I planned to put an iris claw lens. So the day was finally getting over for me. But while putting the iris claw lens, the haptic of the lens broke.
Can you just...
So I took out the lens.
I'll just...
Claw lens, this time successfully.
Yeah.
That's it.
Yeah, and we can have Dr. Shitesh Kumar and a quick question in between.
Yeah, that was a real long day, Dr. Roy. Can we request Dr. Jalali, madam, to give her comments on?
Yeah, two things that, we should always be prepared because we found 2-3 IOLs, 2-3 CTR. So you never know what people have done. They keep on putting, then something goes down, they put again, okay. Just don't damage the retina, it's fine. We can remove my problem happens that if I remove one IOL, then I can bill it for IOL explantation. Now when I remove the second IOL, which is more difficult, I can't bill for second IOL explant. So I bill that as intraocular foreign body removal. I don't want to not bill it. Okay, now I wanted to ask that final haptic, could you find? No.
That small N, ma'am, I could not find, and even the patient has come for a follow-up also.
Yeah, so maybe either it is caught in some serial process, which is okay, it's not going to cause a problem, or it got eaten away during the vitrectomy, which is also fine. And I think if there's a tiny bit left of this material because it is inert, one can leave it alone as long as it is not.
Whether I should have gone for a vitrectomy or not.
Yeah, sometimes. Yeah, but we don't know if it floats and it goes and hits somewhere else.
Yeah, it was bleeding.
Then it's a problem. So if on the table we find something, we have to at least.
I'll add one
Thank
quick
you.
question.
Great.
Did you analyze why did the haptic go off? Why did your haptic break? The first one, yeah. The assistant was no.
The
What you
iris
did not notice it when you were externalizing the haptic. Your one end opening forceps was holding the optic haptic junction. You were holding entire 1 minute. and manipulation was going on, and then you beautifully externalized the haptic. Now what happened when you gave it to your assistant to hold it, probably he or she was not holding it in the correct plane, and there must be some torsion, and it gave way from the optic haptic junction, because there was already a kink at that point with that end opening forces because of the undue pressure which must have come up in your handling. So it was not the assistant.
Yeah, that was a great point. Thank you.
Second thing, if you want to prevent, yes. Second thing, if you want to give your haptic to the assistant, the best thing is if you're using iris hooks, you have those sleeves, silicone sleeves. You can put it on that haptic; it goes nowhere. If you don't want to even spend money on that, you can use the IV set. You can cut that IV set into small, parallel that thing, and you can just insert it into the haptic. It goes nowhere.
Right. Thank you.
Good
That was
afternoon
great.
to all.
Let us
At the
welcome
outset,
Dr.
I must thank AIC and Dr. Sudipta, Mitra, and Dr. Sugato Paul and Dr. Siddhartha Ghosh for giving me this opportunity. My apologies for loading a long video, but I'll be just showing a potpourri of niggles in glued secondary IELTS. So in the interest of time, I'll be showing two cases. So just a moment. So I'll start with the third case. So this was the previous case. So the third case is of a dropped ACIL, and I don't do iris claw lenses, and thanks to Amar sir and Priya Narang ma'am, I'm a hardcore secondary glued IELTS I do mostly. So this was a case of a dropped ACIL, and as we can see that it was entangled in the peripheral vitreous. So it's very important to do a thorough vitrectomy. Now the dilemma here was how to lift up this lens, from which edge to lift it up. So ideally I should have lifted it up from the previous edge, but I lifted it up from this edge of the ACIL. And so what I landed up with is that I could not enclavate it by using the right hand. So I had to switch to the handshake technique and transfer the lens to the MST forceps or the intraocular forceps. And again, using the handshake technique, I enclavated it outside, and rest of the steps were as that of a routine glued IL. So that's the exteriorization of the haptic, and then the trailing haptic was again exteriorized using the handshake technique, which has been beautifully taught to us over last decade by Dr. Amar and Dr. Priya Narang. So that's it, and then moving on to the second case. So it's a case of a topsy-turvy IOL, and it was a routine planned glued IOL surgery in a case of a subluxated lens in a young patient. So after past planar lensectomy, the flap had already been created, and I went in and did a thorough vitrectomy with PVD induction, being a retina guy. So now started with the routine glued IOL, and if you look here, I went to purchase the haptic, and I did not realize something. I did not pronate my wrist, and once the lens opened, to my horror, I realized the lens had been loaded wrongly. So you see, you end up with the haptics being exercised in a reverse fashion. So the difficulty over here is, if you can see that now I want to flip the IOL, and I'm still holding the leading haptic here, and whatever maneuver I'm trying, it's not flipping inside the vitreous cavity. So what I did next was I exteriorized the leading haptic, and that gave me some fulcrum. So if you see here, so I got some fulcrum over here, and then after exteriorizing it, I was able to flip it, and luckily the haptics did not break except for the tip, which got bent, and it did get break. But I was able to complete the case nicely.
Thank you, Shitish. That was wonderfully done. Sum up, Dr. Natarajan. So
I think everybody is being perseverant and patient, and that's important. And I think like whatever tips Dr. Shubhadra gave and all the Dr. Priya and others gave, I think a lot of ways to manage the complications. So I think one thing I learned from my mentor is when complications happen, the chief surgeon has to be more cool, calm, so that he doesn't make tooth tantrums and makes the entire OT strenuous. So I think that's the time you have to use the most coolest, which is you have to develop it. No, nobody will get it, but everybody will respond. And I think you have to, everybody will react, and I think you have to respond. So I think wonderful session, Sudipta, really great, and I think all the panelists are great. So I think I think it's a point to discuss and think more. I think that's the aim of your instruction.
Any quick tip from Dr. Priya ma'am?
Oh, ma'am.
So we have secretary.
Dr. Sudipta, one quick tip from Priya ma'am on the glue.
One quick tip is when you have a 3-piece intraocular lens loaded and when you have to unfold it, you have to just start injecting outside the eye. You just have to see the tip of the haptic and you will get a hint right there. And then you go inside and then you just hold the tip of the haptic, and then as it is twisting, immediately you will come to know whether this is coming on the straight or it's on the reverse. So if you feel it's reverse,
Just come out.
Otherwise you can slowly keep on unfolding.
So it was a busy hour, ma'am. So I had other cases, so I did not see how the assistant had loaded it.
We call this as a lucky 7 sign.
Lucky 7,
it should
yes,
look
ma'am.
like a
Yes,
7.
ma'am. I know. Thank you, ma'am.
Thank you so much. Thank you, the speakers, the expert panel, the chairpersons. Before you leave, can we have just a quick photo session? And thank you, audience, for bearing with us. Thank you so much. And again, AIOS Scientific Committee and all of you for being here. Thank you so much.